So the topic for today is image acquisition protocols in transthoracic echocardiography. And this talk, I've kept it very simple. And the idea is to reach out to those who are starting echocardiography or who are very new in the field. This is not for experts. This is not for people who are well versed with the protocols and well versed with advanced imaging, etc. This is a basic talk, and I hope there will be something to take back from this for all of you. And the other thing is, this by no means is a comprehensive review of any guideline, but there will be certain points of emphasis during different times of the talk, just to highlight certain important things as and when it may come. So I'll go on. You already must have had a talk by Dr. Kapoor a few days ago on different imaging planes. But just to kind of recap and be aware, what you see on the left side here is an individual, and you can see that if the man is divided into two halves, right and left, that is the sagittal plane. And then if it is he is divided into anterior and posterior, that is the coronal plane. And if he is divided into top and bottom, or superior and inferior, that is the transverse plane. The same can be extended to the heart also. The heart, however, doesn't lie in the same position as the individual. The heart's lie is different. So even if you were to extend the same concept to the heart, you would have a sagittal plane, you would have a transverse plane, and you would have a coronal plane. Just to drive home the point. So this is how the heart lies in the body, in the bottom left panel. And these would be the three planes that I have just talked about. But extending this into how it would apply to the heart, you would have the sagittal, coronal, and transverse planes. These pictures are from the guidelines, the ASC 2018 Transthoracic Echo Guidelines, wherein you have the long axis plane, which would be the sagittal plane, and you have the short axis plane, which would be the coronal plane, and then you have the apical plane. So, and the images, corresponding images would be for the transverse plane, the short axis images. For the sagittal plane, it would be the long axis images, the apical long axis image also. And you have the apical four-chamber view, which would be the apical plane. Now, this diagram, it illustrates the different windows through which transthoracic echo is done. Now, what is a window? We have a building or we have a house, and a building or a house has a window. And through that, you can see what's either inside another room or what is outside the house. So likewise, if you imagine the chest wall to be a house and you want to see what is inside, you need a particular window through which you will be able to see. And that is what we mean by window. And you have a bony rib cage, so ultrasound does not pass through that. But there are spaces between the ribs called intercostal spaces, through which you can direct your ultrasound beam, and that will be able to capture images of the heart. Different windows are possible. Like I said, I will be highlighting on the important windows that we will be needing for a transthoracic echo examination. So we start usually with the parasternal view, the parasternal window. Then we come down to the apical window, and then we come down to the subcostal window, and we finish up the study with the suprasternal notch window. There are some other windows also described. I am not going to go into that in this particular session. What is the position of the patient? The patient is usually in the left lateral position. so that, and with his arms above the head like this, so that the intercostal spaces are nice and open, and the heart also comes and lies against the chest wall, so that you can get good quality images. So that is important. So even if you are able to get reasonable images with the patient lying supine, you can turn the patient to the left side so that you get better contact with the chest wall. Intercostal spaces also open up, and you are able to get a better window. This is the 2018 American Society of Echo guidelines that I will be basing my talk on. Almost all the images that I've taken from this particular document. This particular document is available free online, and you can refer to it. And the reason I have taken all the images from here is so that you can relate to it when you read this particular document, and it all appears familiar the next time you look at it. Even the videos that I have taken are all taken from this particular guideline, and all of them are available freely online. This is also endorsed by the Indian Academy of Echo, as well as numerous other echocardiographic societies around the world. So as you can see here, it is also endorsed by the IAE. Going away straight to the views. So our first view is the parasternal long axis view. This is initially taken an increased depth of around 20 or 20 plus centimeters. That is also called a scout view. It is not so much to look at the heart, but to look at what are the surrounding structures around the heart and what is the condition of those particular structures. Especially, it's a good view to look for pleural and pericardial effusion. So to get an overall sense of the heart and the surrounding structures, so that is the initial view that we generally take. Now, comments on tissue optimization, image optimization, all that I will add on as and when required. But again, the focus of today's talk is not so much the physics, instrumentation, or even image optimization. As and when required, I'll add a few points. But the main focus again is to look at the views and what are the structures that we are able to see, how to measure, etc. So this next particular image, this is what we are able to see, that you see the heart here, and behind the heart, you see some fluid here. And you also see some fluid here. So this fluid is pericardial effusion because this is the reflection of the pericardial effusion as you can see, of the pericardium as you can see. This is the descending thoracic aorta that you see here. And you see that the pericardium reflection ends here. So whatever fluid comes in this particular space would be pericardial fluid. And whatever would lie behind the aorta, extending beyond, that would be pleural effusion, as has been shown pictorially in this lower right panel also. So this is an important point to remember. Many a times it may not be very straightforward. It can be confusing, but it's important to try to optimize and try to visualize the descending thoracic aorta and then see how the fluid lies in relation to that. And then we will be able to come to a conclusion. The next view is the parasternal long axis view with a reduced depth. So first was an increased depth, a scout view, and the next would be a reduced depth. So something like 10 to 12 centimeters. Again, that is not a standard fixed thing. You just look at the image and then keep reducing the depth till you get an image which looks like this on the right side. Yeah, so as you can see here, this is not a great image, or this is not the best image, I would say, but this is what I have taken from the guideline document. It is acceptable. And what you can see here is that behind the heart, you leave about 1 centimeter space here. Not on an average, about 1.5 centimeters. Try to fill the screen with the heart. That is extremely important. So you're utilizing all the pixels, all the space that you have for visualization of the heart and the structures that you are going to see. So never confine your echo image or the parasternal long axis view to just this much and try to see what it is saying, and then just leave the rest of the screen blank and empty. Okay, so that is something which is very important to note. And second thing is the sector width. Um, Again, take the sector width, which gives you maximum information in the parasternal long axis or any other view. So if you're able to see all the structures in a given sector width, then that sector width is fine. Don't keep on increasing it or reduce it so much that half the structures are not seen. So an optimal sector width would be that which gives you the anatomic information that you need. So that is about the sector width, about the depth. And why also, the other thing is, why do we need to optimize these two things? Because image resolution or the frame rate will depend on the sector width and the depth. So as you reduce the depth, your frame rate increases. As you reduce the sector size, your frame rate increases. So you want good resolution, you want a higher frame rate. So you keep the sector width to the minimum that gives you all the information that is required. Now, going to how is this image supposed to look? It is supposed to look like how it has been shown here, which is you see the structures here. This is the interventricular septum. This is the posterior wall or the infralateral wall. These are the leaflets of the mitral valve. You see the anterior mitral leaflet here, and you see the posterior mitral leaflet here. This is the left atrium. You see the aortic valve, and you see the ascending aorta here. You see the right ventricle here, and that is the right ventricular outflow tract. The proximal RVOT is what is seen in the parasternal long axis view. Now, the characteristics of a good image in the parasternal long axis, this is a first image. It's very important to optimize your image and get a good view here. So what is a good view? One thing is that you don't see the apex generally in this particular view. So if you see the apex here, then that means that you are low down. You probably need to move a intercostal space up. So that is an important thing to keep in mind. Second thing to note is this is completely parallel in this particular manner, or this is horizontal. You can see that the LV and the aorta are horizontal. Whereas if you see that the apex is pointing upwards and the heart is lying in this particular orientation, then that is not a great view. Sometimes it may not be possible to get this kind of a view where the LV and aorta lie like this. You may have a view which is closer to the apex, and you may get would be an apical long axis view, but that would be in rare circumstances. Most often you should try to get a view which looks like this. The other thing that you can note is that from the probe to the interventricular septum, from the probe to the anterior wall of the aorta, this particular distance on both sides, if it is equal, then that tells you that this is a reasonably acceptable view and that the interventricular septum is horizontal. Whereas, on the other hand, if you find that this is pointing upwards here and this is downwards here, then that is more like a apical long axis view. So those are few things to keep in mind. What you can also see here is a bit of near field clutter in this particular patient. So one way to kind of avoid this might be to try to use the highest frequency probe possible, but then in an adult with harmonic imaging, Many times you may not have a choice but to use the probe that you are already using. The other thing to bear in mind is to make sure that you see the compacted myocardium nicely, that the endocardial border is clearly seen and it is not fuzzy or hazy. Final thing is that you should always try to gate it with an ECG and acquire at least 3 beats when you take this particular view or any other view that follows. So that is extremely important. In this current COVID season, the recommendations are that we try to avoid use of ECG electrodes for concern about spread of infection, and we try to keep the protocol as short as possible. But this is talking about the guidelines and the way we are actually supposed to acquire. It may not apply in the current season when we might alter the protocol. So again, how do we acquire the image? Basically, the probe index marker is towards the right shoulder. And if you imagine the probe to be a knife and your heart to be a solid structure, then you are cutting the heart in this particular direction. And this is what you get when you see it. I've just tried to rotate this particular image to what you see on the right. And this is how it the heart is when a person is lying down. So you might be wondering why it comes out on the screen looking like this, when actually the lie is like this. But if you imagine that you're cutting the heart using the probe in this particular direction, then you will understand that this is how it looks, with your apex towards this side and with your aorta on this particular aspect. And in a good parasternal long axis view, as I mentioned, you would not see the apex at all. This is just to drive home the same point. So if the heart were to lie in this particular manner, you would see the right ventricular outflow tract on top. You would see the left ventricle here. You would see the left atrium here. Sometimes you will see even red flows coming here. That would be from the pulmonary veins. And you would see the great vessels also coming here in this particular manner. Just to go through the structures once again. So you have the papillary muscles. What would be along with this particular wall would be the this is the infralateral wall, and hence this would be the infralateral. This would be the anterior septum, and this is the infralateral wall. And what you have seen here would be the papillary muscle that has been shown. Now you see the aortic valve also here. What you see here is the right coronary cusp. As you can see, it is related to the right ventricular outflow tract. And what you can see is the posterior cusp, and that can either be the non-coronary cusp or the left coronary cusp. What you can also see here in the small, as a small round thing, is a coronary sinus, and you may see that it may vary in size also, depending on whatever the condition may be. So what I have emphasized so far is that we need to have a standard way of image acquisition and measurement. We need to record the clip and measure from the same clip. So it is not okay to just measure online and then we record the clip for the sake of recording it. So that would not be an acceptable way of doing it. We need to record the clip and measure it from the same clip, so that if somebody else also measures it from that particular clip, the measurements and your data remains constant. Whereas if you measure it online and then you just record a clip for the sake of documentation, then the measurements can vary, providing depending on the change in angulation. The other thing is to also use the same heartbeat for systolic and diastolic measurements. So that is also important to note. It is not advisable to use systolic measurements in one beat and change it and do the diastolic measurements in another beat. And the long axis views is what is used for linear measurements, that is your wall thickness, your septum, your ventricular dimensions, all that is from the long axis view. Now coming back to this, everything is from the guidelines, so you can go back and refer at the end of this. So these are long axis 2D measurements. Again, the important thing to note is that many of us would be comfortable, or the traditional thing would be to measure using M mode. But the guidelines do not recommend the use of M mode anymore. So it is good for us to start practicing taking measurements using 2D, especially when we are used to taking measurements on M mode. It will be a bit of culture shift, or a bit of acclimatization, if I can call it, to start getting used to measuring it in 2D. So that is the current recommendation. So again, we have to ensure that the LV is nicely centered. One thing which I did mention is that what do we mean by a centered LV? Apart from the other things that I mentioned, another thing is that you also ensure that the aortic valve is fairly in the center, not too away to this side or this side. So when the aortic valve is fairly to the center, that is another thing to kind of bear in mind. So this is how we measure at the blood tissue interface. You have the interventricular septum, the left ventricular internal diameter in diastole, the posterior wall or the infralateral wall thickness that we measure in diastole. Again, the diastolic frame is when the mitral valve is just closed. The first frame when the mitral valve is closed is the end diastolic frame. Because during diastole, the valve is open, there is left ventricular filling happening. And the first frame when the mitral valve is closed would be end diastole. And likewise, end systole is when the dimension is the least. And again, if you can note, what you see here is that there are no papillary muscles seen. In the anatomical picture that we saw earlier, you could see papillary muscles also in the picture. But here in this particular image, you see that no papillary muscles or chordae are seen. This is extremely important, because if you measure the chordae also, then you will get a fallaciously wrong measurement of the wall thickness. So if it is in the interventricular septum, make sure that you don't take the chordae tendineae or the papillary muscles. That is extremely important. Likewise, in the posterior wall measurement also, it is important to note that you don't take the supporting structures of the mitral valve for the purpose of measurement. This is an old paper which basically talks about the echocardiographic recognition of paraseptal structures. What you can see on top is the septal chordae here on the RV aspect. And what you can see here is the moderator band. And what you can see here in the third image here is the posterior papillary muscle. And likewise, in the posterior wall, you would see supporting structures of the mitral valve, that is the papillary muscle and the chordae tendineae. So this is extremely important to recognize. Otherwise, you can fall fallaciously or wrongly calculate the interventricular septal thickness, and you might call it asymmetrical septal hypertrophy or LVH or such things. So never be in a hurry to start quickly measuring, but try to delineate the anatomic structures very clearly and be confident that what you are seeing is the compacted part of the myocardium and not any of the supporting structures of either the tricuspid valve or the mitral valve. When we measure the long axis, when we do the long axis measurement, it is very important to ensure that it's a very centered, it's a properly centered image. That would mean that we would get the maximum diameter of the left ventricle, as you can see here. So this has been shown with multiplane imaging, that if you take the orthogonal view, the maximum diameter here corresponds to the maximum diameter here. Whereas what has been measured here is that it is off center long axis that has been measured here, and hence this diameter would be wrong. So this centering has been demonstrated using the X-plane or multiplane function in 3D. Now, using the short axis view, we can try to understand the different views that we are trying to study. So this is the parasternal long axis view. And what we are seeing is we are cutting the heart in this particular plane, or cutting the LV in this particular plane, so that you see right ventricular outflow tract on top, and you will see the LV right through the middle. Assuming that this is a nice circle, so that these two walls are also parallel to each other, and what you are measuring in the middle is the maximum. And you are seeing the mitral valve nicely open. You are seeing the aortic valve also nicely open and symmetric in its closure. So that is why I have put this particular aortic valve image here. So if you are not in the center, it is likely that you will find, like if you are to the either to the right or towards the left, what you might find is an asymmetric closure line. So one of the main reasons why you get an asymmetric closure line is an improper plane of the parasternal long axis view. It is certainly a feature of bicuspid aortic valve, and that is since that is a common thing in everybody's mind, it is important to recognize and be sure that the plane in which we are cutting the parasternal long axis view is in the center and it is not off center. Once it is off center, then we cannot be sure about the closure line of the aortic valve. And even if we put an M mode here, that is also doesn't have much value, because what we will see on the M mode is also what we see in the 2D here. So that is about the planes. Now, just while we are at it, this would be the plane of the two chamber. So this is the plane of the two chamber, and this is the plane of the four chamber. I will be showing this also subsequently, but just keep it in mind for now. So what you can see here is that this part of the interventricular septum is the anterior interventricular septum. So this is the anterior interventricular septum, and this is the inferior interventricular septum. So when you see this particular interventricular septum here in the parasternal long axis view, it is best not to call it septum. It is best not to call it interventricular septum also. It is good to be specific and call it the anterior interventricular septum, because as you can see here, this is the plane which cuts it here, and that corresponds to the anterior part of the interventricular septum. It is important to know this because what you see here is not the same as what you may see in the four-chamber plane. The four-chamber plane is in a different plane. It is not the same plane, and hence the interventricular septum that you see in the parasternal long axis view is not the same as the septum that you see in the four-chamber view. Now, is it only an academic thing? No. I mean, if the implications range from, if there is a defect here, you may not see it in this particular view. Or if you have a defect here, you may not see it in this particular view. The other thing also is that the blood supply is different for these particular areas. So that is also important to note. Not all part of the septum has the same particular blood supply. What supplies here is different from what supplies here. And hence it is important to know that what we are seeing here in the parasternal long axis view is not the same as what we are seeing in the four-chamber view. The other thing also to note is that in the two-chamber view, we see only two chambers, namely the left ventricle and the left atrium, and there is no septum or any other part that is seen. I have tried to just show this. This is from the base of the heart with the atria taken up, and we are looking at it from the top. What you see here is anterior. What you see here is posterior. This is the left because we are seeing the mitral valve here. This is the right because we are seeing the tricuspid valve here. And what this is the plane of the parasternal long, or even the apical long axis view. And we are seeing it go through the aortic valve. And if it is taken properly, you will see a proper symmetric closure of the aortic cusp. There is no pulmonary valve or no tricuspid valve which is seen in a proper parasternal long axis view. So that is the other thing to note. Sometimes when you are taking a parasternal long axis view, you might see a bit of the tricuspid valve or the tricuspid valve supporting structures. So in a normal individual, without any anatomic distortions or enlargement of the right-sided chambers, if you start seeing a tricuspid valve or a part of its supporting apparatus, then that means that you are more towards the tricuspid valve. You're more towards the right side. On the other hand, if you are seeing, sometimes you may see the pulmonary valve also in the parasternal long axis view, in which case you may need to align it by slightly counterclockwise rotation so that you get a proper parasternal long axis view. So these are adjustments that are required by looking at the screen, by looking at the image, and making sure that you are really seeing what you need to see. This is important to know because if you know what you are not supposed to see, then you will try to optimize your image accordingly. This is again a parasternal long axis view, and this on the left side would be the correct way to measure the interventricular septum. So what is the difference between these two views? What you can see here is a sigmoid septum or a basal septal hypertrophy that is seen many a time in slightly older people. So when you see this, you do not measure it like has been shown on the right side. Because if you measure it here, then all your calculations would be wrong. You would call it ventricular hypertrophy. The same number would get incorporated into your mass calculation, and everything will be wrong. And the other thing would be that your interventricular dimension here, this also would become smaller, whereas actually the correct measurement would be this. So if the internal diameter is actually this much, the dimension is this much, but you end up measuring a smaller dimension, then that is not a correct thing to do. So hence, it is important to take note of this. When you have a septal hypertrophy like this, you should measure it a little away in the normal part of the interventricular septum. Otherwise, all measurements are to be taken at the tip of at the level of the tip of the mitral valve. These are other 2D measurements that we take. On the left side, you have the right ventricular outflow tract, the proximal part of it, which is again taken in diastole. And on the left side, on the right side of the screen, you have the left atrium measurement, which is again taken in diastole, which gives you the maximum dimension. Again, important to note, as has been shown here, it is measured from leading edge to leading edge. That is from here to here, as has been shown in this particular image. The right ventricular outflow tract image measurement has also important value, especially in conditions like ARVC, where there are specific cutoffs for the different views. So hence we cannot be dismissive, or we cannot take these measurements also lightly. We need to carefully take the right ventricular outflow tract also in diastole, the proximal part of it. Now, coming to the M mode, according to the current guidelines, there is no role for measurement based on M mode. However, still for the purpose of documentation, it should be taken as part of the study, because M-mode still gives us important information because of its higher superior temporal resolution. So the left atrial dimension is one thing that has been taken in this particular image. What you can see in the middle image is motion patterns of different structures. So the mitral valve motion has been demonstrated here. So because of its higher temporal resolution, you can use M-mode to study these particular structures. The other thing that has been shown on the right panel is also that it's very useful for timing events. So especially when we are trying to study dyssynchrony, or we are going to time an event, then this particular thing becomes important. We can use it with tissue Doppler, we can use it with color Doppler, as in the case of mitral regurgitation, or the presence of SAM. All these things can be, this information we can get from this particular M-mode analysis. Now, just a few things about M-mode and how we take it. So here we have taken the M-mode, this is how we have cut it. So you might, when we say measurement of the aortic root, we might be quite okay with it. But what you can see here, that the left atrial dimension is also taken in the same view, in the same particular cut. So what you might get as left atrial dimension may not be the most accurate dimension, because what you see here in blue is what is the, in this particular image, since the left atrium appears to be normal, it may not have much of a clinical bearing, but there may be conditions where your cut makes a very huge difference. And what you may get a proper measurement for the aorta or the aortic root, but your left atrial measurement or your right ventricular outflow tract measurement may be totally wrong. The other thing to note is it has to be absolutely coaxial. So if it is not coaxial in this particular manner, then what you are cutting also will be completely wrong. So that is important to bear in mind. So always, even if you are taking M-mode measurements, please make sure that the image that you are taking is completely centered, it is aligned properly, and just see also what is it that you are measuring before taking the measurements. So this is part of the mitral chordae that you are seeing. This is also important to note, because if you took a M-mode measurement here like this, and you did not separate this particular line from the compacted part of the myocardium, and you measured the whole thing, then your thickness is going to be falsely high, and you are going to be falsely reporting LVH. That is important to bear in mind. So the way to get over it is by optimizing the 2D image and making sure none of these supporting structures come in the image. If for any reason you cannot avoid it, then we have to be discerning in making sure about where we are measuring the taking the readings. Now, this is just a chart. This is not to kind of memorize, or this is just to give an idea. And this is something that we should keep in mind when we are doing echo at the back of our minds. This is from the 2015 American Society of Echo Chamber Quantification Guidelines. I've just taken a few important things and just put it up for your reference. So when we are measuring wall thickness, just to highlight again, many times we don't pay attention. We just measure blindly, or we have a preset idea that 12 is normal. But 12 millimeters is not normal. If you actually look at the numbers in the guidelines, then we become even more careful about even measuring 11 millimeters, because 11 is not the same as 13, is not the same as 9. So we have to be careful in how we measure. This is extremely important. So there is a gender difference also, and you can see the dimensions that have been given here. Mass is also calculated most often from the M-mode measurements, or even from the 2D parasternal long axis view measurements. And that has been, the upper limits are given in this particular chart. Now, quickly going on to the next view. So in the parasternal long axis view itself, we zoom the different valves. So what has been shown here is a zoom view of the aortic valve. This is a very important view, mainly for the purpose of looking at the left ventricular outflow tract. So this is a good view. When we use color along with this, we can recognize the presence of SAM. SAM can be recognized because if you see color turbulence in this particular area, and you see the mitral valve striking this particular septum, when the aortic valve is open, the aortic valve is open tells us that it is systole. And in systole, if we see color flow turbulence here, and we see that there is LVOT obstruction, then that points to the presence of SAM and left ventricular outflow tract obstruction. So that is one thing that you can look at. But most importantly, or in every patient, what this particular image is used for is measurement of the left ventricular outflow tract. And the left ventricular outflow tract is measured by freezing this particular image in systole, so that you have an image which resembles this left panel, wherein the aortic valve leaflets are completely open like this. And then you measure at the hinge point, from this particular point to this particular point at the blood tissue interface. Blood tissue interface means at the junction of the black and the white is where we measure. So that is measurement that we take in a zoomed view so that our measurements are accurate. Never measure in any small unzoomed view. Measurements are likely to be wrong. Again, to recap, this is the right coronary cusp, and this particular cusp could either be the non-coronary or the left coronary cusp. So this is images which are taken from the guideline, wherein this shows the aortic valve annulus at the hinge point. And they have also shown that about 5 millimeters or so below the level of the aortic annulus, you can take your LVOT measurement. However, in practice in our lab, as is the case in many other labs, we take the measurements for aortic annulus and I mean the LVOT also at the level of the aortic annulus itself. The reason why we do this is because this is a fixed point. This is part of the cardiac skeleton, and this is very unlikely to change from examination to examination. And we have a fixed landmark. Whereas if we measure it here this time and the next time somebody else measures it here, there is likely to be a change. And this is a very important measurement, because I will just show you in a moment why it is so important. So this is a given patient here who has a sigmoid septum, as we had seen earlier. So these are real world situations. So what you can see is a sigmoid septum here. So will you measure here or here or here or here? So you have 4 different scenarios, A, B, C, and D. And this is the calculation of aortic valve area by continuity equation. And you might have heard the talk on aortic valve stenosis yesterday or sometime. And you might already be knowing that the aortic valve area, one of the main determinants for calculation of aortic valve area is the aortic annulus or the LVOT diameter. And now, if we were to measure here as in A, if that is the measurement of the LVOT diameter, then by continuity equation, your value is going to be very small because it gets squared, pi r squared. So if the radius of this particular diameter is going to be small, then your LVOT area is going to be small, and hence your aortic valve area is going to be small. So hence the importance of measuring the diameter very carefully and sticking to measuring at the annulus, which takes into account all these situations which we face in the real world. Where do we actually need this? Not in a normal patient where the window is excellent and the valve is not calcified and nice. We need it most often in a patient with aortic stenosis who may have left ventricular hypertrophy, basal septal hypertrophy, calcific aortic valve. That is the value of a proper LVOT measurement. And those particular situations, it may be very hard if we measure ambiguously below the aortic annulus without any fixed reference point. So the recommendation would be to measure at the annulus and not below, though the guidelines say that you can measure it about 5 millimeters below the annulus also. So this, what I have just shown, is an ideal situation in a normal patient where you have a nice box-shaped rectangular LVOT, wherein all these diameters would be fairly the same. But that may not be the case in a given patient where you actually need the LVOT diameter. So that is about measurement of the aortic annulus and LVOT. Now, there are certain other measurements also we need to do in the same view. Again, in a zoom view, what you are seeing here is the sinus of Valsalva. This important thing to note here is that this is an end diastole. The earlier measurement, that is the LVOT and the aortic annulus, was done in systole, mid-systole, with the valve fully open. Here you have the valve closed and you do the measurement in end diastole, again from leading edge to leading edge. So from the beginning of this, that is, this was the top is the leading edge, and to this particular interface, that is the leading edge. That is how we measure leading edge to leading edge. So many times this particular term is used, leading edge to leading edge. Sometimes we may still be confused, but that is what it means. And when we say blood tissue interface or inner edge to inner edge, it would be from this junction of black and white here to junction of black and white here. So I'll repeat that again. This is leading edge going on to leading edge here. And all these measurements of the ascending aorta are taken leading edge to leading edge in diastole. Sometimes in order to see the ascending aorta, the standard parasternal long axis view may not be adequate. So in that case, we need to move the probe and intercostal space higher so that we can see the ascending aorta properly. So this is the probe moved of an intercostal space higher, and then we can see the ascending aorta properly. But there is a practical difficulty. Now, where will you measure? Should you measure at the maximum point? Or because now there are no landmarks. I told you for the aortic annulus, you have a nice landmark. That is the hinge points here, the hinge point of the mitral valve here, hinge point here of the aortic valve, and you can measure it here. But for ascending aorta, there is no such hinge point or no such landmark. So that becomes difficult because we measure it here one time and somebody else may measure it here the next time. And there may be no chance, or follow-up becomes extremely difficult. One way to do it is to identify the aortic ascending aorta from a higher intercostal space and try to visualize the maximum that you can see. So you know that you have tried to see the maximum possible ascending aorta, and then see where is the maximum diameter. And then try to see how far that is from the aortic annulus. So you can measure it that way. Say we are measuring it here, here, and say that is about 4 centimeters from the aortic annulus. So then we can report it as by saying that the ascending aorta measures 4 centimeters or 40 millimeters at a distance of 40 millimeters or 4 centimeters from the aortic annulus. So that the next time somebody measures it, they know that they should be measuring roughly 4 centimeters or 40 millimeters away from the aortic annulus. So that serves as a landmark for further follow-up. So this is just to summarize what I have just said about aortic measurements. So these are the standard measurements which are all given in the guidelines. I'm not going to go into great detail here, but the points that you measure, one is the aortic annulus or the LVOT, the sinus of Valsalva, the maximum point, the sinotubular junction here, and the ascending aorta. So these are the standard 4 measurements that you take. There are other measurements also that you can take, the aortic arch, the descending thoracic aorta, abdominal aorta, that I'm not going to go in this particular talk. There are guidelines and documents available. This is the purpose of this slide is just to highlight that such data is available, which you can go and study and look at. And now this is also something to know, that the aortic root diameter, again, it is not a standard one size for everybody. So again, in the guidelines, the chamber quantification guidelines, you have different nomograms like the sinus of Valsalva. You have for children and adolescents, for adults 20 to 39, adults more than 40. And you can kind of plot and see where it fits in. If it fits in within this box in any of these age groups, that means you are good. If it is outside the box, then you know that it is dilated. And again, it differs for males and females. So you may not be able to see the details, but the idea is not to confuse you with the details. The idea is to kind of highlight that these kind of nomograms are available, measurements and other guidelines are available for aortic measurements. Now, like I had mentioned earlier, once you are done with the aortic valve, again, you zoom the mitral valve. You look at the motion of the mitral valve leaflets. You look for any kind of prolapse. You look for any thickening. You look at the subvalvular apparatus, as you can see here, the chordae. You see whether there is any restriction of motion. The hockey stick appearance that is described for the of the anterior mitral leaflet and mitral stenosis can be seen in this particular view. You can also put color and look for any abnormal flows, look for any regurgitation. The one point to note here is that the direction of regurgitation here can give you an idea about which particular leaflet is prolapsed in the case of mitral valve prolapse. So to put it very shortly, if you see a jet going here posteriorly like this along the posterior left atrial wall, then the prolapse is likely to be the anterior mitral leaflet. Likewise, if you see a jet going here like this, then it is likely to be the posterior mitral leaflet, which is the problem. So these are certain things to look at. Again, one technical tip, always zoom. That is something I have mentioned, because for the given number of pixels, you are seeing a much larger part of the heart. So mind you, this particular space that you have has a fixed number of pixels, and you can choose to occupy only this much of the, fit the heart into this much of area, in which case that will be the resolution. Or you can select a given portion of the heart and use the same number of pixels to see that particular structure. So obviously, if you are just seeing the mitral valve using such a large number of pixels versus you seeing the whole heart in this much, seeing the heart, just the mitral valve leaflets with so many pixels would give you definitely a better image. This is slightly different from magnification, wherein you may lose the number of pixels by blowing up the image, but that is just a technical point. The other thing is that you keep this color sector box as small as possible, but at the same time making sure that it covers the area of interest. So again, you don't want the box covering the full sector width here. So that way your resolution, your frame rate goes down. Now it doesn't really matter how big you make it from top to bottom like this. What matters is how much you make it from side to side. So if you widen it side to side, your frame rate is going to go down. So that is important to keep in mind. This is just to give you an idea about color compare. This is something that this is not from the guidelines. But time is a constraint for most of us, and hence it may make better sense many a time to use color compare to quickly come to the assessment of what we have talked about. Now, in the parasternal long axis view itself, there are two other views that we need to go to, and that would be the right ventricular outflow tract. So what you can see here is the right ventricular outflow, and you can see the pulmonary valve here. and you can see the main pulmonary artery here. So that is what has been shown here. So this is also a good view to look at PR. You can look at the valve leaflets. You can look at PS also. You can take gradients also. You can also measure the pulmonary annulus in this particular view. So these are all things that you can do with this particular view. Now, this is the parasternal long axis view, the RV inflow view. And what you can see here is the right ventricle on top, the right atrium here, and the tricuspid valve here. What you are seeing here is the anterior tricuspid leaflet. And what you are seeing here should be the posterior leaflet, tricuspid leaflet. But in this particular image, you are also seeing the left ventricle, part of the left ventricle here. So when you see the left ventricle here, what you are seeing here would be the interventricular part of the interventricular septum. And hence, in that case, this would not be the septal leaflet. This would be the posterior, this would not be the posterior leaflet. This would more likely be the septal leaflet of the tricuspid valve. Other two things that you can see here, one is the inferior vena cava that you can see here. The other thing is this particular, the eustachian valve that you can see here. And the other thing, just below the tricuspid valve, there is another orifice that you see, and that would be the coronary sinus. So you see the coronary sinus, you see the eustachian valve, and you see the inferior vena cava. The superior vena cava would come from somewhere there. So these are all things to note and keep in mind. Now you can use color here. As I have already mentioned, we look at the TR, and the gradients can be taken here for measurement of PA systolic pressure. So again, to look at the tricuspid valve, to look at the coronary sinus, to look at the tricuspid regurgitation, use multiple views. Again, the basic thing in echo, don't come to a conclusion based on only one view. Use multiple views to come to a diagnosis of a given condition. Now from here, we rotate the probe, and now the guideline talks about these maneuvers. Many times, those of us who are doing it regularly, we may not even know what we are doing, but we are already doing it. But then just to know what is it that we are doing, we are actually rotating the probe as we have shown here on the right side towards the left shoulder, and we get the image that is shown here at the bottom. And the structures that are seen here would be the pulmonary valve. You see the aortic valve here in the center, the tricuspid valve, the interatrial septum. This is a very nice, important view for the interatrial septum. And when there is a doubt about foramen ovale or even ASD, this would be an important view to look at. And this would be your aortic rim here in case of an ASD, and this would be your posterior rim in case of an ASD. What you see here is the left atrium. And you would also be able to see the left atrial appendage here many a time. Sometimes you can also see a red flow coming here. That would be the left-sided pulmonary veins also coming into the left atrium. This is at the level of the great vessels. This is an important, the point of putting these next few images is that you take it step by step and you take it structure by structure. Don't try to acquire all the information that you want right from one image. The reason is because the aortic valve is not at the same level as the pulmonary valve. So this is at a higher level. You are not seeing the aortic valve leaflets, but you are seeing some part of the pulmonary valve leaflets. And that is because both are not at the same level. So if we want to see the pulmonary artery well, we focus on that and take an image which shows us that well. If we want to see the aortic valve, we focus on that, zoom it, and we see that. If you want to see the coronaries, you may need to go a little higher up than the valve, and then you might see it. If you want to see the interatrial septum, that may be at a different level. If you want to see the tricuspid valve, that will be a different view. However, all of them are parasternal short axis views around the same kind of orientation. So it depends on the structure that we are looking at. Never come to a final one image is not enough to show all the information that we need. This is again the same thing in moving film. So what I've tried to show here is you can see that this is not really coaxial. And this is like really far off away. So a gradient that you take in this particular direction may not really be very great or very accurate. So you need to make that straighter, you need to align that better in order to get a better gradient. Likewise, you are not seeing part of the right pulmonary artery. The right pulmonary artery you're not seeing. You're seeing part of the left pulmonary artery. So that is the importance of taking focused views. Now, this is a particular CT image. Now, everything, this is the age of multimodality imaging. This might just suddenly come to you as a shock, or it might take, but there is nothing very complicated about this particular image. This is really the parasternal short axis view that we are seeing. You have the sternum here. This is an axial cut. This is sternum here, the aorta and the spine at the back. And this is the heart in the center. The left atrium is the posterior structure. As we have seen in the previous image, the short axis view, you are seeing the aortic valve also here. Your interatrial septum would come somewhere here. And this is your right atrium, right atrial appendage, your RV outflow tract. And depending on the level, you would see the PA also coming, something like that. So the reason for putting this up is that you will see part of the pulmonary, left-sided pulmonary veins, appendage, everything also in this particular area of the parasternal short axis view. So sometimes when you use other modalities also, it enhances our understanding of echo and what are the structures that we are looking at. Now, this is at the great vessel level. This is again important, the measurements that we take here. This is again not the same as the parasternal long axis view, though this is the proximal RVOT. This measurement is not the same as the parasternal long axis view. In the parasternal short axis view, this is the RVOT proximal. This measurement is different from that in the parasternal long axis view, and the cutoffs are different. And for a condition like ARVC, the numbers also are different for diagnosis. This would be the distal RVOT. This is the proximal RVOT. This is this here would be the PA annulus also, and this would be the main pulmonary artery. That is somewhere in the middle of the pulmonary artery. And this is how we take the RVOT pulse wave Doppler. We put a pulse wave Doppler and we can trace to take a VTI. We can see what the acceleration time is, and that gives us an idea about the pulmonary vascular resistance, about the pulmonary arterial pressure. So all those kind of information also we can get from this particular Doppler. So always do a pulmonary or RVOT Doppler, which tells us about the forward flow in the pulmonary artery. So a condition with where your RV ejection is low, this will be small. A condition where the vascular resistance is high and ejection is low, again, this may be reduced. A condition like ASD or anemia, this will, which is a high flow condition, your RVOT Doppler may be increase. That is the importance of looking at this and recognizing patterns. Similarly, for pulmonary embolism also, you may be able to pick up, depending on where your notching is and how steep this is, the location of the thrombus also. So it has multiple utilities, so always try to appreciate. The thing, one important point also about all RVOT Doppler, or any such thing in echo, is that if we reserve it for a special occasion or a time when and not make it part of the routine examination, and we have not seen hundreds and hundreds of RVOT Dopplers or patterns, then there is a pathology or when there is an abnormality, then at that time, many a time, we may be unsure of these things. Hence the importance of looking at RVOT Doppler or any such thing also as part of standard examination. So next you can do a continuous wave Doppler, and that will tell you the gradients, and you can see whether there is pulmonary stenosis here, there is a bit of pulmonary regurgitation, And the pulmonary regurgitation, the end diastolic velocity, it tells you about the PA diastolic. When you add the right atrial pressure, the early part of it, that tells you the mean PA pressure. So these are all data that you can get out of a PR jet. So this, as you can see, is at beyond the end of the T wave. And here, this is the P wave. So all this is part of diastole, and this is a diastolic event, whereas the forward flow is a systolic event, and that is seen in the systolic part of the cardiac cycle, and that is seen both in the ECG as well as the echo. So you can correlate. So the ECG is hence useful for timing events also when you are unsure. So that is, I was just telling you about taking proper focus views. So this is just to look at the PA. This is not a great image per se in terms of quality, but in terms of the alignment and all, this is fine. Wherein this is now quite perpendicular. And a Doppler that is taken from something like this would give us better data as compared to what I showed you a couple of slides ago, where all the structures were seen in the short axis view. So again, the importance of taking focused views in echo. This is to show the parasternal short axis view of the aortic valve, zoomed, very important when you're looking at aortic stenosis, to look at the morphology of a valve. So if you see that the valve is very thickened or calcific or hardly opening, it is likely to be significant aortic stenosis versus something which is opening nicely like this. The leaflets are thin and opening well. So what you're seeing is the pulmonary valve here. What you are seeing here is the right coronary cusp, and a simple way to remember that is that this is related to the RVOT. And this is this particular cusp is related to the interatrial septum, which comes here. So what you can, how we can remember it is, what is related to the RVOT is the right coronary cusp. What is related to the interatrial septum is the non-coronary cusp, and what is left is left. So that is a simple, easy way of remembering the different cusps that are there. You would see that a coronary artery arises here, that around 4 o'clock position, that would be the left coronary artery from the left coronary cusp. Likewise, from the 10 or 11 o'clock position, you would see a coronary artery arising here, and that would be the right coronary cusp, the right coronary artery. This is the same thing with color. And what you can see here, there is a bit of aortic regurgitation. Important note, sometimes to note whether it is bicuspid or tricuspid. The important thing is to keep it open in systole and then see, because sometimes they can be lying like this, and that might indicate a raphe. So not in the closed position, but in the open position, you try to see how many cusps there are. And here in diastole, you can see that there is a bit of a leak, and that is aortic regurgitation. This I just told you about the origins of the coronary arteries. Now, again, next view is to look at the, again, these are all short axis views, but now it is focused on the tricuspid valve, as you can see. So this view is slightly different from the pulmonary artery view, as you might have realized that they are all in different planes, and hence would require a little bit of manipulating the probe to be able to see the structures well. Now from here, that is what we mean by angling the probe. So just bringing in those particular terms also. Now we go to parasternal short axis view at the level of the mitral valve. And what you can see here is the anterior mitral leaflet, and what you can see here is the posterior mitral leaflet. The important technical thing to remember is that the right ventricle should be seen on top like this, and not at the bottom or the side. The other thing to note also is that this should be a nice circular image, and all the walls should be nicely seen. While I say that, it is important to also note that sometimes you may need to acquire two separate images to see the mitral valve and the endocardium. We see the endocardium for wall motion abnormalities at the basal level. For that, you may need to take a slightly different image. As you can see here, this endocardium is not very well seen here. So I might want to take a slightly different image for the endocardium, whereas for the mitral valve, this is a good image, and I might be okay with this. So that is just one technical thing to remember. Now, your left atrial appendage comes this side, and hence in your nomenclature of the mitral valve and the segments and scallops, this would be your anterior mitral leaflet. This is the posterior from appendage towards the medial side. This would be A1, A2, and A3, your P1, P2, and P3. So this is a good view to also look at where there is a prolapse. So sometimes or many a time, this is in 2D itself, you will be able to see where the prolapse is. So this is a good view to see that. This is the anterolateral commissure. This is the posteromedial commissure. This is also the view in which we do the planimetry of the mitral valve in diastole. Not in a normal patient, but in a given patient with mitral stenosis. So this is this is just to go back. Sometimes this may not be seen as a perfect circle like this, but you may see a kind of beaking that is seen here. Now, it is important to recognize that, and you may see a kind of endocardial dropout also there. It is important to recognize that as you are going from the ventricular aspect towards the aortic valve, that is from inferior, from below upwards. So you are seeing the mitral valve apparatus, you are seeing the mitral valve, and this is what you are seeing here is the LVOT. So that is the part of the LV or the LVOT that you see sometimes in the short axis view, which you need to be aware of. And then, of course, you reach all the way up to the aortic valve, and the pulmonary artery would be somewhere here. Pulmonary valve is there. So that is going from below upwards. So to know that we need to try as much as possible to get a perfectly round LV. And this particular color also helps us localize where the leak is. So if there is a leak happening here, then it is likely to be from the one segment. Whereas if it is from here, it is likely to be from the three segments. Something in between would be from the two segment. And as I told earlier, looking at the parasternal long axis view itself tells us whether it is anterior or posterior. If something directed posteriorly, it is likely to be an anterior leaflet problem. Now coming to the papillary muscle level, this is the anterolateral papillary muscle, and this is the posteromedial papillary muscle. Generally, this would be at the 4 o'clock position, and this would be at the 8 o'clock position. Now, this is a position which is important to note because this is how it normally would be, but this doesn't come automatically. It depends a lot on the way you acquire and take the image. Now, you can acquire an image where your RV is on your left side, and these orientations are completely distorted. So it is important to get a nice circular image of the left ventricle. This is your interventricular septum. This is the anterior part of the interventricular septum. This is the inferior part. This would be your inferior wall. This is your infralateral wall. And this is your anterolateral wall. This is your anterior wall. So that is how the whole thing is divided into each into 6 segments. I'll come to that in a bit. This is at the level of the apex. Now, at the level of the apex, what is also important to note here is that you don't see any RV in a normal patient. So without any RV enlargement, generally, you should not be able to see any right ventricle. So if you are seeing right ventricle in a normal patient, that means that your image is not okay at the apical level. So how do we get these different short axis views perfectly round? That also I'll just come to in a short while. So this is these are anatomical views that you are seeing from the base to the apex. And as you can see at the apex, you are not seeing any right ventricle at all. Whereas here, you are seeing right ventricle. So that is, unless there is right ventricular enlargement, you would not see any right ventricle at the apex. So the important maneuver for getting these cross sections is by sliding the probe. The sliding the probe is not the same as tilting the probe. So as you can see, you are physically moving the probe so that you are using it like a knife to slice it at different levels. So if you imagine the heart to be an apple, you want different slices at different levels. So that is done with the parasternal views. Now we come to the apical views. This is the apical four-chamber view. Just a few technical things about the apical four-chamber view. Again, like I said, the centering is very important. So the interventricular septum has to be right bang in the center and absolutely straight, perfectly straight in the center. The other thing to also note is that the left ventricle should be a nice bullet-shaped cavity like this without any foreshortening. I'll just show some images of that. And the structures that we see here would be the left ventricle, the left atrium, the anterior mitral leaflet, the posterior mitral leaflet. This would be the anterolateral wall. This would be the inferior septum. So as I kept repeating again and again, this particular part of the interventricular septum is different from what we see in the parasternal long axis view, wherein in the parasternal long axis view, we see the anterior part of the septum, the anteroseptum. This is the inferior septum. This is the right ventricle that we see here. This is the septal leaflet. And this is usually the anterior leaflet of the tricuspid valve, but it can also be the posterior leaflet. This is the right atrium, and here we see the descending thoracic aorta. So this is the normal orientation of the heart in the body. So how do we get the four-chamber view? Is that if the heart were to kind of be, you turn it so that you make it straight like this, vertical. That is not what you see on the right is not the anatomical position, and you've just made it vertical. And this vertical heart has been cut. You will get the appearance looking like this inside. And if you turn it the other way around, looking at it from the bottom, you would see the heart looking like this. That would be the four-chamber view. So wherein the chambers I just mentioned. Now, we not only take a four-chamber view as I just showed you, but we also have to take a focused view by reducing the depth. And that is highlighting only the left ventricle. Again, important thing to note is that you see a bit of the atria. Don't just completely cut off the annulus, in which case your measurements are likely to be, it becomes difficult to measure. This is also a view that we take to for quantification of strain, and we usually measure about 3 beats. So again, important to see the best possible images, see the endocardium nicely, and make sure that there is no apical foreshortening, that the apex, that the left ventricle appears nice, elongated, banana-shaped or bullet-shaped, as you can call it. We can go to the two-chamber view, wherein you can see the anterior wall here, you can see the inferior wall here, and what we can see here is a mitral valve. You can see a bit of the left atrial appendage. This is a view to see the left atrial appendage apart from the short axis view for LA clots in case of mitral stenosis or AF or any such condition where there is left atrial dilatation. This is a view where you can see left atrial appendage transthoracically, and this would be the inferior wall, and this is the anterior wall. The same thing in the focused view also we need to take. Now the focused view of the four-chamber and the two-chamber is what we use for measurement of the EF biplane, which I'll just come to in a minute. And we go to the three-chamber view. You have the anterior septum. This is similar to the parasternal long axis view. All the structures are also the same, except that you see the apex in this particular view. Again, you see the apex nice and pointed. If you see the apex which is fully rounded, then that apex is a foreshortened apex. Whereas if you see an apex which is nice and pointed, that is likely to be a good apical image, a good image for the purpose of measurements. Now this is also the same view in a focused view. This is the infralateral view, and this is the anterior septum. It is good to get used to these terms because it is not difficult at all. It is good to keep using it day in and day out so that it becomes part of our vocabulary, so that when you're reading something or when you're talking to another person also, you're using standard, well accepted terminology and not confusing terminology, which sometimes can cause confusion. So this is about the regional wall motion abnormalities, which is not really in the scope of this particular talk. But I will just quickly highlight that the different coronary artery territories are highlighted here. As you can see, the anterior wall is exclusively supplied by the left LAD or the left anterior descending artery. The anterior septum is also exclusively supplied by the LAD. Whereas the infralateral wall that is shown here can be supplied either by the RCA, right coronary artery, or the left circumflex. Now, a very simple thing that you can remember is that if you find that this particular wall, the infralateral wall and the anterolateral wall have wall motion abnormalities, it is likely to be circumflex. Whereas if you find in the two-chamber view that the inferior wall and part of the basal inferior septum is hypokinetic or akinetic, then the culprit vessel is likely to be RCA. The posterior descending branch of the RCA is likely to be the culprit. That is just very broadly. So this is all again there in the guidelines. As you can see here, the different coronary territories have been shown. I don't think I have very much time more, so I will quickly try to take you through the next few slides that I have. And so this is the anterior aspect. This is the anterior descending artery. And what you can see here is the atrioventricular groove, which is perpendicular to this particular plane. And in the left side, you have the left coronary artery in red, and here also you have the right coronary artery. So what I have shown you is the areas which are corresponding to these coronary arteries. This is looking at the heart from the back, and this is the posterior descending branch of the right coronary artery in the right atrioventricular groove. And in the left atrioventricular groove here, you see the coronary sinus coming in like this. And so coronary sinus, remember, is a posterior structure which drains into the right atrium. So this is just to highlight this also. So this is an image just to show that the plane of the left anterior descending artery is not the same, or is perpendicular to the plane of the left circumflex on the left side, on the right coronary artery on the right side, and that is the atrioventricular groove. This is the interventricular groove. So both are perpendicular to each other. So that is just to bear in mind. Now, the different walls and the wall motion, again, corresponding, you have the two-chamber, which is cutting like this. So this is the short axis view. You cut the two-chamber view like this. You get anterior wall here. You get the inferior here. And then it's just a matter of calling it basal, mid, and apical. Basal, mid, and apical. Likewise, you have the four-chamber here, anterolateral and inferoseptal, as you can see here in the blue. And this corresponds to the short axis view. Again, it's just a matter of calling it basal, anterior, anterolateral, mid anterolateral, and apical, like that. Likewise here. So that this is something which is again there as part of the guidelines, which you can again continue to look at. Different methods of quantification. You have the 2D, you have the 3D method. So I'll just stick to the 2D measurement and the principle behind it. The principle is that the left ventricle is divided into multiple discs, as you can see here. And that is seen in the four-chamber and the two-chamber view, as you can see here. The multiple discs are seen here, and it's just the volume is just the summation of these discs. You do this in systole, you do this in diastole, and the difference is what is the stroke volume, and that divided by the end diastolic volume gives you your ejection fraction. So that is a very simple way of disc summation. Now, measuring LV volumes, this is just something you start from here, go along the interventricular, along the compacted myocardium, as has been shown. You end here, you don't come all the way here, and you ensure that this particular line goes to the apex and is perpendicular to this annular plane. So that is important to ensure, and I'll tell you why in a moment. And also, it is important to ensure that you don't include these trabeculations. So these are all trabeculations. The correct way of drawing would be to take the trabeculations also as part of the cavity. So you take the true compacted myocardium. This image is from the guidelines, and what you can see here is that all these things, you have a papillary muscle, you have non-compaction here. So all this is also taken as part of the cavity. Avoid foreshortening of apex, as I've already told you. So this is an image for foreshortening. So as you can see, this green plane is the plane through which is going through the true apex, whereas this light green is not good through the true apex. So what you might see is a very thick apex here, which is contracting vigorously. whereas the true apex does not contract that vigorously. And so when you see a heart like this, you will find that the whole heart is more roundish as compared to a more elongated shape of the heart. So our endeavor should be to get a heart which looks like this rather than a rounded heart which looks like this. I was just telling you about why it is important to ensure that it is perpendicular and make sure that there is no dead space like this. So now this part is not included in the volume calculations. So that is the importance of taking it perpendicular to this annular plane. So these are all part of the guidelines. I'm not going to dwell on this, but to know that in the 2015 ASC guidelines chamber quantification, these numbers are all available for ejection fraction. I'll just highlight that the normal values for male lower limit for EF was 52. For females, it was 54. Just bear that in mind. And for EDV, it's 62 and 46. Now, if you remember those numbers, I'll just tell you one more bit of data that has just come in recently. The other thing is that for all measurements, such nomograms are available and they can be made use of. These are again available in the guidelines. I've just kind of shown one of such nomograms for the end diastolic volume. Now, I was just telling you about this particular, now what are normal values in Indians? So as part of the ASC guidelines, you have all the numbers that I showed you. But for Indians, this is something that I pulled out from the WAY study. And what you can see here is that end diastolic volume, which was 62 and 46, is 47 and 40. So Indians are smaller. This is non-indexed. And when you index it, it becomes even smaller. Likewise, EF also, the lower limit is 58, as you can see in both males and females. For GLS, the lower limit is minus 17 or minus 18. So this is just a table that I kind of compiled based on the WAY study, which came towards the end of last year. As you can see, again, the interventricular septum, also the lower limit is 5, posterior wall also the lower limit is 6. So these may all have a bearing on how we interpret our measurements. So now, what should we be following? All that is still up to individual lab practice and question. But it is good to stick to standard ways of acquiring, standard ways of reporting, and be aware that these numbers are not fixed, and it will depend on the size of the individual, it will depend on the race, and it will also depend a lot on what is emerging data. So this is just to show the LV GLS. This is GLS is normal, nearly minus 25 in this particular patient. From the apical views, we can go to the measurement of the chamber volumes. Left atrial volume, as you can see here on the right side of the screen, has been shown. So you have you take it in end systole when it is largest, and you start from the medial part of the annulus. You trace along the interatrial septum. You go all the way. You don't take any of these pulmonary veins. Exclude the pulmonary veins. Exclude the appendage here, and come to the lateral part of the annulus. And then also you ensure that this particular length is absolutely perpendicular to the annulus. So then, only then this particular volume will be correct. And you do the same for the two chamber. What about the view itself? The view which gives you the largest size would be the view to take the volume. And that sometimes will cause some amount of LV foreshortening. So that is again an important point to note, is that for the purpose of LA strain or volume, you can take another view, which is not the same as the first chamber view that we used for Simpson's for LVEF. We can take a different view which gives a larger image, better clarity, and try to take the volumes there. We can even zoom for better quantification. Right atrial area, again, we start laterally and we trace all the way down, go up the interatrial septum. End here, we don't close it, end here, and then we get the right atrial area. This is again with color. We can use color compare also. This is a patient with some mitral stenosis, some regurgitation. Again, the direction of the jet, it gives you a qualitative assessment of the regurgitation also. So color also is to be used. Now, Doppler measurements, which are part of standard examination, you do a pulse wave Doppler by placing the cursor at the tip of the mitral valves. You see this mitral inflow. This is the E wave, which is seen in the early part of diastole. This is the A wave. As you can see, it is after the P wave on the ECG, just before the QRS, because this is as a result of atrial activity. So this is the A wave. So you see, you measure the E velocity, you measure the A velocity, you measure the deceleration time. So these are standard measurements that are taken. Now, important to also note where you place the cursor. So this is a very old study, and many such data is available. So here it is at the leaflet tips, and this is the data that we get here. Here it is at the annulus, and this is how it looks. So if you place it at the leaflet tips, it may look like this. Whereas if you go more towards the apex, again, it may start looking like this. If you come towards the annulus, it looks like this. So again, extremely important to know where to place them. It is at the tips that we place the cursor, and that is how we measure it. So that is again just to highlight that. This is that sometimes you may need to use Valsalva again for left atrial pressure assessment. That I'm not going to go into. But sometimes when you have tachycardia, you can have fusion. The important point to note here is that this velocity, this point here, where the E wave ends and the A wave takes off, if that velocity is greater than 20 centimeters per second, then your deceleration time is not accurate. So don't measure deceleration time in that particular case. This is in a patient with mitral stenosis. You can trace and measure gradients. You can do pressure half time, as has been shown in this particular image. Other things that we can get are tissue Doppler, again, to be routinely measured. You can take it medially at the base here, and you can take it laterally at the base here. What you see here, this is the S wave that is seen in the S wave because it is in systole. This is systole that you see here. This is E prime and this is A prime. So you are seeing that in these two waves, this corresponds to the E in mitral inflow, this corresponds to the A in mitral inflow. And so those are the waves. Apart from that, you have isovolumic waves also, but these are the major waves that you see here. Another important thing to look at is the pulmonary veins. And this would be a zoom view of the left atrium in the 4-chamber view, and try again to angle it and see. You will see a right pulmonary vein, either the superior or inferior, coming in like this, and with red flow. And if you do a pulse wave Doppler, that gives you waves like this. This is the S wave in systole. This is S. This is D in diastole. And this is the atrial reversal, which comes after the P wave. So those are the three major waves. Again, extremely important. It is useful for diastolic dysfunction. So very quickly, if I have to say, if the left atrial pressure is high, this systolic wave will be blunted. So that is one thing to note. The other thing is, if there is regurgitation very severe, then this may even get reversed. This may come in the opposite direction. So that is something to note. So looking at this is also extremely important. Again, like I mentioned earlier, these are not skills which suddenly come when you need it. So hence, it is good to do it in every given patient and try to get the pulmonary veins and try to get the Doppler. So the Doppler cursor should be placed about 5 millimeters or 1 centimeter into the pulmonary vein. So see the pulmonary vein nicely. You can zoom the view, use a narrow sector, put color, and then use the cursor well within the pulmonary vein. And now about the 5-chamber view, again, becomes important for LVOT Doppler. So this is sweeping from 4-chamber towards 5-chamber, and you can see the aortic valve also open up. The structures have been shown here. They are easy to understand. So you can take the LVOT Doppler in this particular manner. So sometimes when you have LVOT obstruction, like in HOCM, you can have flow turbulence there, and you will have the LVOT Doppler going up a lot. So in that particular case, you can either use pulse repetition frequency, which may be an automatic feature in many echo machines, or you can use continuous wave Doppler. Now, where should you place the cursor? You place it in an area of laminar flow, that is blue flow, in the LVOT, where there is no mixing of colors, and keep it as close to the aortic valve as possible, about 5 millimeters or so within the aortic valve. Now, sometimes you may need to go up towards the apex, especially if there is turbulence, and then come back into the LVOT to see where is it that the velocity is the maximum. Sometimes you may find turbulence arising in the mid part of the LV itself, in which case you take it all the way up to the apex and then you slowly bring it down and see where is it that the obstruction or the gradient is. So that is to localize the point of obstruction or origin of the gradient. So this again is a normal patient, and you have you can use color flow to see where is the turbulence, whether it is at the apex, whether it is at the mid part of the LV, or whether it is there is a subaortic membrane which is causing it, or whether there is a SAM, or is it the aortic valve itself. So this localization is extremely important, and not just merely putting a continuous wave Doppler and saying that the gradient is 5 meters or 4 meters, because that doesn't tell us exactly what the problem is. Sometimes there have been instances where there has been a subaortic membrane, or there has been HCM, and it has been wrongly attributed to as aortic stenosis, and the therapies are entirely different. So the importance of knowing where is it that the gradient is originating. So this is just the tracing of the continuous wave Doppler in a case of aortic stenosis. This I'm not really going to dwell on. This is the aortic regurgitation. Again, the slope is important when we have to assess the severity. Now, when we tilt it a little posteriorly, we get the coronary sinus, and that is with a posterior tilt, as we can see here. So this is a four-chamber view. Again, this is a CT image, the sternum here, aorta and spine at the back. And we can see that it is not very hard to understand or very difficult. So this is also, purpose of putting this is also to kind of explore and try to see whether we can look at other kind of images also to build our understanding of anatomy as well as the imaging modality itself. I told you the coronary sinus was at the back. So when we tilt from an apical four-chamber view, posteriorly, we get the coronary sinus. And when we tilt it anteriorly, we see the aortic valve and the pulmonary valve, as you can see in this particular sweep. As you can see here, this is the aortic valve, and you continue to sweep. In a patient with a good window, you will be able to see the pulmonary valve also. But this is very hard in most patients, I would say. Only in those with good windows, you might be able to see this. But if you see this, great. So this is to show how you are basically, this is tilting the probe. So what you have here is the four-chamber view, and as you tilt it anteriorly, you see the aortic valve and you see the pulmonary valve. So this is an anterior tilt. If you go posteriorly, you see the coronary sinus, which is a posterior structure. So in other words, if you see a coronary sinus in a four-chamber view, you know you have to tilt it slightly anteriorly. Or else if you are seeing the aortic valve open, then you know you need to slightly tilt it posteriorly. And this is essentially the four-chamber view. The view is exactly the same as a four-chamber view. You have just tilted it so that you are seeing the right ventricle here. So here again, note that the ventricular, left ventricular shape is maintained. The shape has not got deformed. It's not foreshortened. The apex is still here. You've just adjusted the image in such a way that you are seeing now the right ventricle in the center of the screen. Any kind of right ventricular quantification should be done in this particular view. Whether you take your TAPC, now you can nicely align it, or your S prime tissue Doppler, or whether it is fractional area change, any kind of measurement should be done in this particular view. Again, this is from the guidelines, right heart guidelines. The importance of putting this up is that here you can see that the LV in all these three images is looking the same, but what is looking different is the right ventricle. So right ventricular size in the four-chamber view becomes very important to look at with multiple adjustments. So as you can see, it changes a lot as you adjust, but more or less the left ventricular size does not change much. So whatever gives you the maximum size is the correct one. So in this case, it would be this particular image. This, as I said, you can take these measurements at the base, at the mid, the length. So there are values for this. You can take it then diastole, systole, see what the area changes. So that would be the fractional area change. This is the measurement of the TAPC. Again, you've taken a zoomed view. You have aligned it well so that it is straight and not oblique. And then you're measuring this vertical height. Though what is shown here is the slope. But what is measured as TAPC, tricuspid annular plane systolic excursion, is the vertical movement of the tricuspid annulus. This vertical movement is what we are measuring here. So this is, I already talked about this, the vertical movement. You can also measure S prime by tissue Doppler. This is a slide which is somebody else's. But what it shows is that if it is off axis, then your measurement can be underestimated and you will call it RV dysfunction. So that is the importance of even aligning it properly for TAPC. And according to the guidelines, you need not quantify this E and A velocities, but it is good to record it and observe the pattern. You take a TR velocity also. Again, my next thing would be on hemodynamics. I'll deal more on measurement and estimation of pressures there. This is a subcostal view. And here, as you can see, this is a good view to see the interatrial septum. And what you can see here is the interatrial septum, because ultrasound beam is nice and perpendicular to this particular interatrial septum. So you can look at color flow also. This is one of the main utilities of using the subcostal four-chamber view for the interatrial septum. Now, just to note that interatrial septum dropout can be seen in four-chamber view. So that many times is wrongly reported as an ASD. But when we look at the subcostal view, there may not be any ASD. That is the importance of looking at the subcostal view for the interatrial septum. There are other subcostal views also, but that I'm not going into right now. These are my last few slides. This is to look at the IVC. So what you can see here is how the IVC also collapses with respiration, and you can see how it is aligned. You can see the liver here on top, and you can see the right atrium, and you can see the eustachian valve also. What is shown here is how the IVC moves and collapses with respiration. If you see an IVC like this, that means that the right atrium, right atrial pressure is normal. Whereas if the IVC, even with sniff, is fully distended, that means that the right atrial pressure is high. So it's as simple as that. So this can be seen either in 2D or you can use MO to delineate this. Now, to see the hepatic veins, again, you might need to do a little bit of adjustment so that this middle hepatic vein comes absolutely in line with the cursor, so that your measurement is correct and it is in line. So the view which gave you the IVC will not give you this. You need to slightly go clockwise, and then you will see the hepatic vein. And then you can do a pulse wave Doppler. Again, like I said, sometimes we get very flustered when we look at these images and we don't know what is happening. Always have an ECG. It will solve a lot of problems and it will really enhance your learning. So, except for this COVID season, I would like to reiterate that we should be using ECG for every examination. And what you can see here, this is systole, this is diastole, this is A wave, the late part of diastole. And what you can see here is just the opposite of what you saw in the pulmonary venous Doppler, wherein this wave, which is labeled as 1, is the systolic wave that corresponds to this, that is systole. This is D wave that is in diastole. And this is the A reversal that is seen in the late part of diastole. So the waves are exactly the same, except that the direction is different because the direction of blood flow is different. And finally, you come to the arch view. And what you see here is the innominate vein, which innominate artery, which goes to the right side and gives rise to the right carotid and the subclavian vein. And for the left, you have the left carotid and the left subclavian vein. So this is a view to look at coart. It is a good view to look at PDA. You also see the right pulmonary artery. So sometimes for shunts and all that, which have been done for congenital heart disease, many times these are all views. And you can see collaterals also in this particular view. You can see coart. You can see aneurysms, dissections. So many things you can see in this particular. Make this part of every routine examination. Again, I would like to emphasize that if this is being done only when it is absolutely required, it's very unlikely that you will be confident of the view that you are getting. Whereas if this is part of a routine examination, then you will see all shades of aorta. You might pick up incidental atheromas. You will see how it is supposed to look. You will see what are the difficulties that you encounter in different patients with different habitus. So that is why I would encourage you to really try and do this in every given patient. Now, these are not my recommendations. These are the society's recommendations, and I have just stuck to only those bare minimum recommendations. So that after this, if you go and open the guidelines and go through it, you will find that everything that is being discussed today is exactly verbatim what is there in the guidelines. So these are the ascending aorta pulse width Doppler, and this is the descending aorta pulse width Doppler. So now, as you can see, when I given patient with AR, you can see diastolic flow reversals again. If you don't have ECG here, sometimes you will be wondering what is happening, what is systole, what is diastole. But here you can say that this flow, this is the forward flow in diastole, this is the backward flow in diastole. So this is systole, this is diastole, and this is a reversal that you are seeing. You can use M mode also. You can use color M mode also, and that will also tell you the direction of the flow. Just a quick, the final thing would be to look at saline contrast, since it is part of the guidelines also. So this is, and also not only is it part of the guidelines, this is commonly a thing which comes into the echo lab many a time to look for either a PFO in somebody who's had a stroke, or from hepatic medicine, hepatology, to look at any extrapulmonary, extra cardiac shunts as part of hepatopulmonary syndrome. So this is how it is generally done. So as you can see here, this is the first beat when it is fully opacified. You can see an IAS aneurysm also here. But very shortly, within a few beats, you can see that the left ventricle, left atrium, left ventricle is opacified. And just showed it, this is within 3 or 4 beats. So that means that the shunt is an intracardiac shunt, and it is not taking a long time to cross over to the left side. If it is taking a very long time to come, that means that the shunt is not within the heart, it is outside the heart. So you think of aortopulmonary collaterals elsewhere. And this is, you see that in the end it clears off also. This is a patient with liver disease and hepatopulmonary syndrome. And here you can see that it comes in, but it comes in through the pulmonary veins, and it comes in after more than 4 to 6 weeks. So you need to count, and the counting starts once the right heart is completely opacified. So we can say that left heart opacification happens or is noted these many beats after complete right heart opacification. And that is suggestive of an extracardiac shunt in this given patient. So that is also how we generally word and report these patients. Now, the idea of putting this is not to take you through each thing, because all of these things I have kind of demonstrated and shown today. But this is part of the AAC guidelines and the protocol. So when we say protocol, these are all the different things that we go through. All of these things have been shown today. Nothing extra has been shown, just so that we stay focused and we stay in line with what. So all of these things have been mentioned. what are the images that you're supposed to take, what are zoom views. As a rule, zoom all the valves so that you can see better, put color, and take a clip. When it comes to Doppler, there is no need to take a clip or a video. You can just take a still image because if you take video for or a clip for Doppler data, then unnecessarily you'll be taking a lot of space and wasting data. So this is quite extensive. So many views are there. I would also like to tell you that there is the Indian Academy of Echo guidelines in 2015, and those are also very comprehensive and very user friendly. Thank you all. Sorry for exceeding the time. I'll be happy to take any questions if any. Yeah.
The first question is it possible to see pulmonary valve in short axis view? Is there any pathological condition that shows the good pulmonary valve?
Yeah. So I must say that there is no standard view which shows the pulmonary valve in short axis view. As in where you can see all the leaflets on fast, that would be extremely difficult. And certain modified views, like how we take the aortic short axis, or if the pulmonary RVOT is dilated and the pulmonary annulus is also dilated, then sometimes you may be able to take it with slight modification of the view. The other thing we can do sometimes is that what I showed you initially about the parasternal long axis view of the RVOT, if we kind of make the pulmonary valve a little horizontal, and then we can use X-plane or a multiplane, then that can, especially with a 3D probe, that can tell us about the pulmonary valve on fuzz. But otherwise, yeah, in short, there is no standard view which tells us pulmonary valve.
Perfect, sir. Perfect. So is there any fixed range of dimensions for RVOT, MPA, LPA, and RPAs?
Yes.
And the guidelines available?
Yeah, these are all there. I did not go intentionally through this because for each measurement, there is value available. It's all there in the guidelines. You can look at the chamber quantification guidelines, and it is impossible for any one person to remember all the things. So it is always good to have, especially when we are starting off either in the mobile phone or put it up in the form of some charts which are easy to remember next to the echo machine, and not clog up your brain space trying to remember 100 or 1,000 different numbers. Yes, there are cutoffs that would be according to body surface area. It would be different for a child. It would be different according to gender. Best to have nomograms, charts, and all displayed.
Fine, sir. I think the next question is about the basic Doppler. What is the difference between PW and CW? Which one to use when? And there is another question from the same participant. How to take Flax RVOT view?
Yeah. While I'm Flax RVOT view, so how to take it is from the standard parasternal long axis view, you just go slightly clockwise and towards short axis, and you tilt it slightly downwards, and that would give you your RVOT view. In the next patient, you can just try it. And when we need the RV inflow view, that is to show the tricuspid valve, you point your probe towards the right hip, that is the opposite side. So this RVOT view is one thing to look at the pulmonary valve. There is another valve, another view which can be used for the pulmonary valve from the parasternal long axis itself, which I did not talk about, and that would be that in the same position as you have for the parasternal long axis view, you just tilt it upwards slightly, and in some patients you will be able to see the pulmonary valve. So that is a non-modified view for the purpose of looking at the pulmonary valve. Now coming to the question of continuous wave Doppler and pulse wave Doppler. So I'm not going to go into the physics and all that, but just to kind of in a very simple way, where we, to measure high velocities or where we expect high velocities, we will use continuous wave Doppler. So that means if there is aortic stenosis, say for example, velocities are over 2 meters, 3 meters, 5 meters, 6 meters, those would be continuous wave Doppler. Whereas low velocity flows, which is like flows from LA to LV, like the mitral valve, unless it is stenotic, normal flow, the velocity is very small. So hence we would use pulse wave Doppler. So low velocities, we can use continuous wave, pulse wave Doppler. High velocities, we can use continuous wave Doppler. The other thing is also the problem. The problem of continuous wave Doppler is what we call as range ambiguity. Range ambiguity means you are not able to localize exactly where the signal is coming from. So you can have, like say in the parasternal 4-chamber view, velocities coming from apex till the aortic valve or even beyond. And you put a continuous wave Doppler, it will give you the perfect or the maximum velocity along that line of interrogation. But you will not know whether it is arising at the mid cavity of the LV, whether it is in the LVOT, whether it is at the level of the valve or it is above the level of the valve. Those things you will not know. So that is the problem with continuous wave Doppler. The problem is range ambiguity. Whereas pulse wave Doppler helps you localize where exactly your high velocities are coming. So using a combination of the two enables you. So essentially, one more thing to also note is that color Doppler is a modification or a different representation of pulse wave Doppler. So it's doing exactly the same thing. So in order to localize, you can use color Doppler or pulse wave Doppler. But in order to know what is the maximum velocity, you will use continuous wave Doppler.
Fine, sir. Thank you. And there is hundreds of compliments coming in your way, and there are hundreds of people asking, if we can retelecast this, or maybe we can upload the recorded session in the YouTube. Definitely, we'll do that in the later point of time. So moving on to the next question: how to measure LA volume index?
Yeah.
I think is it? Are you would like to answer this, or we will be covering the hemodynamics in your next presentation?
Sure, I can do it again at that time. But to put very simply, you just take a 4-chamber view. It is not the same view as what you measure your left ventricular volumes. Because again, why is it not the same? Again, important to know that cardiac structures are not all in the same plane. That is, the LA is not in the same plane as the LV. The angles are different, and hence the view which gives a perfect LV may not always give the perfect LA also. So you first of all, 4-chamber view, but it may not and need not be the same as that for the left ventricle. Second thing is, left ventricle may not be seen very nicely. It may be a foreshortened LV, doesn't matter. But if the LA is seen nicely, it is at its widest. You look at the end systolic volume because that is when it is maximum. That is the largest diameter in the 4-chamber view, largest diameter in the 2-chamber view. You trace from the medial part of the mitral annulus along the interatrial septum, excluding the pulmonary veins, excluding the left atrial appendage, go to the lateral annulus. That gives you your 4-chamber LA volume. And you do the same thing by excluding the left atrial appendage, pulmonary veins, starting from the inferior part to the anterior of the annulus. That gives you your 2-chamber volume. And the average, biplane average volume is what you would report. Now you index this to body surface area, or you already enter height weight in your system. Most systems would calculate body surface area and the values would automatically be indexed. So you will get your indexed. Anything more than 34 is the cutoff, 34 ml per meter square body surface area. It's a dilated LA. Yeah.
Perfect, sir. There are a few questions about the right parasternal window. So what is the indication to do the right parasternal or a back, window, and how it should be done in normally patients?
Yeah. So the right parasternal window, again, I'll just stick to one condition in which you must do it. And this is any patient with suspected aortic stenosis. Even if you don't do it for anything else, it's fine. So how do you do it? You put the patient in the right parasternal, right lateral position. For the standard imaging, it's in the left lateral position. Whereas in this case, you will put the patient in the right lateral position with the right arm above his head, not the left arm. And then what you will do is to keep the probe on the right side, exactly like how we keep for the left parasternal long axis VOT. And then you you rotate the probe clockwise so that you see the ascending aorta. Again, one important thing to note here, it is not so much seeing the structure itself, but you see it with color. So the view that gives you maximum color turbulence, you put a continuous wave Doppler. So don't be discouraged or don't give up saying that I can't see anything. The reality is when we are assessing patients with aortic stenosis, many of them might be elderly, windows might be bad as it is. And when you are beginning to take right parasternal window, the truth is that many times you may barely be able to see the heart. But use color, use these few tips that I mentioned, and try to see where the maximum turbulence is, and take the continuous wave Doppler. Always measure everything at a sweep speed of 100 or more. Put the baseline down. What you measure is what is above the baseline, because the direction of flow is towards the transducer. Tracing that would be the BTI of the aortic valve.
Thank you, sir. Thank you very much. There are a couple of more questions. What's suprasternal short axis? What is suprasternal short axis? And how to look PLSVC?
Yeah.
Persistent left superior V-neck.
Yeah. So one of the things, so again, like I mentioned, these are things you can, unless it is shown, it may not kind of register. It is there in standard literature. I have skipped many things. I've just stuck to the things that are absolutely mandatory. And with the different orientation of the probe with the suprasternal position, you would be able to get a suprasternal short axis view also. It is not something that we routinely use for most patients. For most patients, what we routinely use is what I have just talked about. But I will just add that sorry, Indresh, what was the second thing that you said?
PLSVC, sir.
About a persistent. Yes. Yeah, one of the clues is a dilated coronary sinus. So when you have a dilated coronary sinus, one of the most common thing is persistent LSVC. Oftentimes, just a dilated coronary sinus without any apparent cause itself, most likely it is persistent LSVC. If you really want to image, you can kind of go a little more laterally on the towards the left, suprasternally, and you might be able to see blue flow going down towards the heart, and that would be your left SVC. But there are other ways also by giving contrast, etc., wherein you might find that the contrast first fills up the coronary sinus before filling the other chambers. That also indicates. So from a left brachial vein, we give saline contrast, and that will go towards through the left SVC into the coronary sinus first before filling the chambers. So if you can see that this dilated coronary sinus fills first before any of the chambers, So that tells us that it is a persistent LSVC. So these are again some ways of knowing.
Moving on to the last question, probably.
Yeah.
Can you please tell us the tips and tricks to calculate an accurate mitral valve area by planimetry, especially?
Yeah, I'll just mention it, but I think that should actually ideally be part of mitral stenosis talk itself. But very quickly, one of the things is that you take a good short axis view. Um, Many a time actually the mitral valve anatomy itself is distorted. So sometimes what you may actually encounter is that you get a good short axis view. The ventricle itself looks nice and round, but then the mitral valve you are not able to see very well, or you are seeing something which looks very big, much bigger than what you expect or what you are seeing in other views. So then what do you do? And that has to be, that is because of the orientation of the mitral valve opening within the left ventricle, or rather from the left atrium into the left ventricle. The orientation of that particular orifice is such that even if many times we get a perfectly round short axis view, it may not give the measurement at the tip of the mitral valve. So what can we do? One is to manually try to go towards the apex and then keep coming up towards the base. And the point at which you are seeing the valve at its narrowest, you can freeze it. Again, standard things remain. Always zoom, always that is maximize the depth, the sector size, the all instrumentation, because these are again difficult patients that you are trying to image. Don't be in a hurry. Optimize your image first. Optimize the zoom. Then as you are coming from the apex towards the base, the point at which you are getting the valve the smallest, that is where you have to freeze. You can record it, and then you can measure it when it is widest, that is in diastole. Now, another very useful thing that we use very routinely for measuring is the use of the X-plane or the multiplane. So in the parasternal long axis view, again, that is a very important thing. When you have the parasternal long axis view, you have the X-plane cursor coming exactly at the tip of the mitral valve. You know where you're aligning it. Whether you're aligning it absolutely straight and perpendicular to the axis of the mitral valve. In that case, the orthogonal view that you get on the right side of the screen would be your a perfect mitral valve, and then you can planimeter that. The third thing, of course, is 3D, which is has been out of the scope of today's discussion. But in short, that if you have a 3D machine, use X-plane or multiplane, align it nicely in a good parasternal long axis view, and the orthogonal view that you get, you magnify it, freeze it in diastole, and you trace it. That is probably the best you can do. If not, if it's an old, you are stuck with old technology, then try to take it from apex to base, the best possible image, and try to measure it.
Sir, there is a last question, and there are a couple of people asking about the same topic. How to see right aortic arch?
How to see right aortic arch? Yeah, so this, again, many a times it's something where a patient with congenital heart disease may come. Many a times the commonest would be tetralogy of Fallot, and aortic arch is something that we should comment on. So the way that we generally look at the aortic arch is to keep the probe in the suprasternal notch with your index marker towards 1 o'clock position, and that is how you get your standard view. And this probe is usually placed towards the left of the midline or towards the left of the trachea. And if you find that, what I'm telling is a very simple and a very useful way of kind of coming to a conclusion very quickly. Now, if you find that using the standard method, you're not able to see it, but on the other hand, you are able to see it towards the right side of the trachea, then that points towards a right-sided aortic arch. And even the branches, all the branches come out from the right side. So that is in short how we routinely check the sidedness of the arch. Sure, Hitesh. Thank you very much. Thanks.
Thank you so much, sir. Thank you.
Thank you.
You've been very patient.
Good night.
Good night. Good night, everybody. Thank you so much for joining.
Thank you, Ranjit. Thank you, sir, again. Good night. Good night, all the participants.